been seeing patients for a long time. I finished med school here in 1976, so 43 years I've been seeing patients, and a fair number of those have been difficult. And I figured, I've got ideas about how I approach those, and look forward to sharing that with you. But I thought, well, y'all don't want to just hear my opinions. Let's see what the literature says. So I really got in and looked at a bunch of articles. Unfortunately, there's not a lot of evidence-based medicine on this topic. But there's a fair number of articles and some recommendations, and I'm going to share those with you. But I want to start with this question. How many of you in here have at some time had an encounter with a difficult patient? Med school or residency? Hands high. Maybe it's easier just to say who has not. No hands at all? No hands. Okay, so that means all of us have had an encounter with at least one difficult patient. But what does that really mean? So what are some examples? Now, I don't want a whole case presentation, but just like, what's the basic problem? Now I get to come pick on you. What? Angry. Why might they be angry? Because they don't want to be in the hospital. What else? That's an option. They did what 2 minutes ago? Okay, a moral flaw. That was in the literature. That was one of the underlying problems, having moral character flaws. What else? So they're angry about something. Okay. Already angry. Okay. What else? Misunderstanding. Okay. What else? They didn't like to wait in the exam room that long, or even wait wherever, in the ER or whatever. What else? They're scared. All right. So think about the last time you were really frustrated with a patient. That patient, what was that patient doing that caused you to be really frustrated? How about wouldn't take their medicine? How about asking you for stuff you thought they shouldn't be asking you to do? Any others? All right, well, I'm going to show you what's in the literature about that. I think y'all have got a really good start on it. The goals, though, at the end, be able to define patients, difficult patient, and consider some alternative terms, list some common causes of difficulty with patients, describe options for managing difficult patients, and then list benefits of compassionate care for both, and this is critical, patients and caregivers. I'm going to turn this one off. I'm going to stay up here for now. So still on? Okay. So, what defines a difficult patient? What I found in the literature. Definition: patients who raise negative feelings within the clinician, frustrations, anxiety, guilt, dislike, despair, anger, and then overall those mean that's a stressful situation for the clinician and seem to be due to inappropriate behavior in a treatment setting. Now, who decided it was inappropriate? Well, obviously the physician decided, or the caregiver decided it was inappropriate. Well, how common is this problem? Well, that was an interesting answer to that, because it was somewhere between 15% and 60% of the patients were deemed difficult by their physicians in the literature. And there's 3 different articles here that said that. But why in the world would there be such a variety, such a wide range? It's very common, but it estimates vary widely. Turns out, and from what I've seen in some of the articles, that the more senior physicians, the ones who have been around longer, had a lower percentage of difficult patients. So you have something to look forward to, fewer difficult patients as you get older. Some examples. Now, we talked about several, but this one I got out of a family medicine journal. Drug-seeking behavior, asking for excessive or inappropriate narcotics. Quote from the patient, "None of these medicines work for my pain." And then the sickle cell patient, who always asks for a specific medication and a specific dose during their crisis. Time demanding, always exceeding the designated limit, then hurt or angry when departure is required. Seductive patients, same or opposite gender. Non-compliant patients, almost all patients are non-compliant, but the ones that are more blatant are really frustrating. How about this example? A 58-year-old man with chest pain, ST elevation, positive cardiac enzyme, who refuses admission to the hospital. Don't you know that would be frustrating for that ER doc or the cardiologist who wanted to help that patient? I'm going to come back to that case later. Self-destructive behavior, excess alcohol, tobacco use, and then the doorknob complaint, oh, by the way, which is the real problem they came in there for to begin with. They just failed to tell you about it the first 20 minutes. Can you give me a work excuse for last week when I was sick? Now, I'm angry because you made me wait too long. Someone mentioned that one earlier. Could you see these other three little ones while we're here? They all have the same thing. Parent who insists upon accompanying the adolescent child when the adolescent child is talking about things they don't want their parent to know about. Then the patient who wants you to keep looking, that I know there's something wrong with me. And then the one that praises you and then asks you for something that you don't want to give them. You're the best and only doctor. And then finally, I'm a medical malpractice prosecution lawyer. Okay. So, what are the consequences? When we deal with difficult patients, what happens to us? We have decreased confidence, self-confidence in the clinician, disruption and decreased productivity for that particular visit, decreased production for the subsequent visits for the day or afternoon, disruption and decreased quality of time spent at dinner or with family or recreation, so it kind of ruins the evening, maybe ruins the night, you don't get a good night's sleep, maybe causes feelings of self-doubt, inadequacy, even resentment, and eventually, with enough difficult patients, burnout happens. So what's the underlying problem? Why are there difficult patients? And this, again, from the literature, what I've seen listed here. Maladaptive personality traits. Patients go about asking for what they need in ways that we feel like are inappropriate. Then the white supremacist problem, the flawed moral character, mental disorders, and there's a wide host of those, especially personality disorders like borderlines. But any whole host of mental disorders can cause that patient to be perceived as very difficult. And then the difficult maladies, and the best example of that is probably a sickle cell patient that has frequent crisis. But many other difficult maladies would go into that category that lead to that difficult encounter. And you see the references here from those. Specifically on sickle cell patients, what's the problem here? Well, if you think about it, and the patient has recurrent pain crisis, so they have true pain, and over a long period of time, they're going to end up requiring much higher doses of narcotics than most other patients to get their pain relief. So that increased dose is a red flag. Providers perceive that a high tolerance is just evidence of opioid abuse and addiction, and that patient has had multiple episodes of pain crisis, has been in the hospital multiple times, and they know the name of the medicine and the dose of the medicine that has helped them the most the last time. And they're maybe asking specifically for that, and the physician thinks, it's my job to decide what you need, and they don't want to hear it. And I'm not saying it's give them everything they want, everything they might need, but the sickle cell patient is challenging in lots of ways, and at least trying to understand it from their perspective is part of the solution. Other options to manage difficult patients. Well, I'm going to present some strategies, but before I do that, I was also asked to present how do you go about firing a patient. So that's sort of the bottom, that's the last end result. If things don't work out, you dismiss them, fire them, eliminate them from your panel. So how would you go about doing that? And even though this isn't the best way to handle a difficult patient, sometimes it's really necessary. And if the relationship is such that both the patient and the physician are not getting any benefit from it, it's best just to terminate it. Okay, so how should you go about that? Important that you follow your residency policy, your hospital policy, or the State Board of Medical Examiners policies. So they are in place most of the time. When I was residency director here for family medicine for 26 years, about every year we had at least one or two times when a resident would come and say, this patient is doing such and such, I can't see them anymore, we need to just kick them out of the clinic. And so it happened a fair amount. So I developed a policy, and our policy in family medicine was, one, the resident had to put in writing a description of the behavior that was inappropriate, and then focusing on the behavior, not on other characteristics like the person is just mean. So what was the behavior? And then that needed to be presented to the next resident meeting. We had weekly resident meetings, and it would be voted upon by the residents as a group. Guess how many votes were not unanimous to kick the patient out? 0. So the residents always believed the other residents always were in favor of doing what the primary resident had recommended. So that triggered a final warning letter. And the final warning letter says, you've had some, it was a form letter, but and it says that you have demonstrated some unacceptable behavior, and you, over the next 2 weeks, need to come in and talk to the medical director about that, who was me, and if you want to continue to be seen in this clinic. If you don't want to be seen in the clinic, we will continue to care for you for 30 days, and then you need to seek care elsewhere after that. Most of the time, over probably 2/3 of the time, the patient would actually come in, and we would talk, and we would look at what the behaviors were, and they got a chance to vent too, but there was always some of that. And a lot of the times, the patients would change their behavior and would continue to be seen in the clinic. So, and if they didn't, then a termination letter would be sent. Now, the exception to this was violence. If they threatened violence, then they were just automatically terminated. But otherwise, they got the warning letter and a chance to fix the problem. The State Board of Medical Examiners in Louisiana has policy, and they say physicians have an obligation to support continuity of care for their patients. While physicians have the option of withdrawing from a case, they cannot do so without giving notice to the patient, the relatives, or responsible friends sufficiently long in advance of the withdrawal to permit another medical attendant to be secured. So otherwise it would be abandonment, and that's not good. Then they go about giving some recommendations to specifically accomplish that task. So the recommendations from the State Board of Medical Examiners in Louisiana: notify the patient in writing of the intent to dismiss, give a specific date, generally 30 days, provide a brief explanation of why you're terminating the doctor-patient relationship, document the notification and reason for termination in the medical record, assist the patient in locating another provider by providing reference sources, transfer all medical records to the new provider immediately upon receipt of valid patient authorization form, follow HIPAA, assure the patient has adequate refills of maintenance medications to assure continuity of care. So those are the steps that the State Board of Medical Examiners recommends. Ochsner Health System has a policy for seek care elsewhere. These are the guidelines for Ochsner. Now, for this hospital, although operated by Ochsner, hasn't really addressed these guidelines to my knowledge yet, but I can tell you what the system does. And they look at these 5 categories of reasons for patients to be dismissed or need to find care elsewhere. Patient who fails to show up for appointments, no shows. Patient has made a serious and repeated lawsuit threats to a physician or provider. A patient has displayed hostile behavior while in the clinic, before, during, or after their appointment time. Patient failed to use narcotic medicine in accordance with the provider's prescriptions, directions, or instructions. And then finally, patient has made a threat of physical violence toward the staff or institution. So the number 3 was hostile behavior, but it wasn't really a threat of physical violence. The number 5 triggered a process that was much more expedited. The other 4, there was a process for each of those that was different. And they would try to deal with the problem first. And they had to get approval by whoever the medical director for the clinic was. So there was a process for each category. And I'm not going to spend time doing all that. We haven't adopted those yet for this hospital, but they may become in place at some point. So if you're going to discharge a patient, Do it according to the guidelines that you have for your clinic, your residency, your hospital, and your state. So, if you don't discharge them, what else can you do? This was from a family medicine journal, Family Practice, from a number of years ago. They interviewed a bunch of family physicians to try to address this question of how to manage difficult patients as perceived by family doctors. Well, the end results recommendations were that the physician should appropriately use the doctor-patient communication skills to improve relations with the patient. Okay. You should use empathy, tolerance, and non-judgmental listening. And then they noted that the more experienced the doctor is, the less he perceives patients as difficult. So that's maybe one of the reasons some of the physicians thought only 15% of their patients were difficult. That didn't mean they didn't have any, but they had much fewer number. And they think that the more experienced physicians learn to accept greater diversity and variable behaviors in their patients, so they just sort of tolerate it more. Another article, this one's in the dermatology literature, how to optimally manage unhappy, anxious, and difficult patients. They went through that article with a number of caveats and some specific recommendations for various caveats, but I really wanted to just emphasize what their conclusions were at the end. They said the key to patient satisfaction includes empathy, a strong patient-provider relationship. It's not coincidence that they put patient first. A provider's sincere effort to practice patient-centered medicine, and all of that means compassionate care. Communicate with the patient using simplified everyday language. Actively listen to patient concerns. Ask about the impact of the patient's disease on their psychosocial life, and a genuine concern for the patient's perception of their illness. So there was a lot of emphasis on trying to understand what the underlying problem is and looking at it from the patient's perspective. So that was dermatology. Here's one from the British Medical Journal. Some general practitioners were having a lot of problems with difficult patients in their practice. And so they started studying those patients, and they categorized those patients into 10 different categories, trying to understand what the underlying problem was. They categorized them as black holes, punitive behavior, complex medical problems, complex family issues, and there was a list of 10. I'm not going to go through all those. But at the end, what I saw was their conclusions. Often there was a family secret that was the basis of the problem, and patients don't make sense. So often there's something going on that's not obvious at first, but if they look closely enough, they were able to find it. Following the studies, the authors re-examined their own management so that they actually approached patients differently after they started studying the problem. And many of their most difficult patients seemed less troubling. So just studying the problem helped fix the problem. There's another study from the American Journal of Bioethics, a couple of them here, shifting from the difficult patient to the difficult relationship. So that's a shift of focus from on the patient's problem to a relationship problem. And then another one, distinguishing difficult patients from difficult maladies, so that, like the sickle cell patient, it's a very difficult malady and it's a difficult issue for both the physician and the patient. And so shifting the blame to the problem, to the malady instead of the patient was helpful. So after looking at all of those and thinking about my approach that I've had with patients, I've got some recommendations for you, some sort of bottom lines. Number one, seek understanding of the underlying problem. Ask the question, what's causing this patient to act this way? And try to figure that out. And there can be a wide range of answers to that question. So go into it open-mindedly and try to figure that out. Reframe it. Difficult patients, instead of looking at it as a difficult patient, look at it as a difficult encounter or a difficult malady. And that came straight out of the literature as a recommendation. So focus on the encounter, on the relationship, on the malady, instead of the patient as the whole problem. Discuss the case with a senior attending. In family medicine, we have Ballant groups, and we do a lot of discussion of difficult patients in Ballant groups. You will also have, the interns here will all have process groups, or most of you will, for your residency, and you'll have a monthly process group where you can talk not only about your rotation problems, but you can talk about your patient problems too. Rename the difficult patient. Call that patient high maintenance. I don't have difficult patients anymore. I have no difficult patients in my practice. I have a lot of high maintenance patients, but I don't have difficult patients anymore. When I was in high school, I had a 1948 Willys Jeep that was put together from junk parts. My grandfather owned it. It wouldn't run. He said, if you can start it, you can have it. So I towed it home and went to work on it. And over the next 2 years, my last 2 years of high school, I worked on that old Jeep more than I drove it. But I loved that old Jeep. It was the most high-maintenance vehicle I've ever had any contact with. But it was a great vehicle, even though it was really high maintenance. And I have some great patients, even though they're high maintenance. So don't have difficult patients. Just have high maintenance patients. And then ask yourself the question, maybe you could be a high maintenance doctor. Ask yourself the question. You know, when I see residents and other physicians talking about their difficult patients, my first thought is, I just wonder how many patients out there right now are talking about their difficult doctor. You know, and that sort of pops into my head every time this comes up. I wonder how many patients are out there right this minute talking with their friends and family about their difficult doctor. How many difficult patients feel that their doctor just doesn't listen? How many feel they have not received compassionate care? And finally, how many have had harmful interactions with physicians? So I'm going to tell you about a case. Is this still on? Yeah. So when I was 12 years old, my dad was a cattleman, raised beef cattle. He was physically a very powerful man. He graduated from LSU with honors in animal husbandry, and he raised beef cattle. Part of raising beef cattle is making hay for them. So when he was 40 years old, he was running a hay baler, tripped and fell into the hay baler. End result, amputated both arms above the elbow. So very, very minimal residual arms. He spent the next year in a couple of different hospitals, multiple surgeries, and most of the time was a VA hospital in New Orleans. Eventually he came home. I knew it had been a really challenging experience, of course, but he never talked about it. Never said much about his experience in the hospital or rehab. He had 2 artificial arms. He became pretty self-sufficient after that. It was pretty amazing the things he figured out how he could do things. Never talked about his experiences until I was accepted to medical school. And as soon as he found out I was going to medical school, he said, "Son, I need to tell you about my experience at the VA hospital. Not having arms, I was totally relied upon everybody else to do everything. I could do absolutely nothing. The only place I could get blood or start an IV was feet or legs. So it was overall a bad experience. But the absolute worst part of that experience happened one day on rounds when a group of interns came in, and the resident who was leading the group came in and was telling the team about this case. And he said, this patient used to raise cattle, beef cattle, but now he's sort of quartered. That's a term that's used when you butcher cattle. When he told me that, he said, that was really, really painful. And I've made a decision. I'm never going into the hospital again. I will never be admitted to a hospital again. So I didn't think a whole lot about it. I knew he was serious, and I knew he was really stubborn. But 18 years later from that episode, he presented at age 58 to an emergency room with chest pain, EKG changes, enzyme changes, refused admission, and died at home a few days later. So that harm that resident did ended up in that decision, refusing life-saving care. What you say and how you say it matters. If you can't be compassionate, at least don't do harm. But better be compassionate, and I want to show you this. I've got a 15-minute video that's going to tell you something about compassion, about how important it is, and how you might actually do it.
In my job, I meet people on the worst day of their life. I'm an intensivist. Day of their life. I'm an intensivist, a physician who specializes in intensive care medicine. If you become my patient, it's because you need life-sustaining therapies in the ICU. Lately, I've been rethinking how I care for people. Let me tell you why. On February 27, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, 2 buses collided head-on. This is what was left of one of the buses. 6 people died, but miraculously, 56 people were saved. 5 years later, researchers asked the question, what do survivors remember? They interviewed every survivor, and using a rigorous qualitative research methodology, they found 2 common themes in the data. The first was expected, the physical pain that they felt at the moment of impact. But the other theme, a lack of compassion from the caregivers at all the hospitals. That's what they remembered 5 years later. These data have begun to open my eyes to a stark reality. In healthcare, we are in the midst of a compassion crisis. Scientists define compassion as an emotional response to another's pain or suffering involving an authentic desire to help. It's different from sympathy or empathy, which are the feeling and understanding components, in that compassion also involves taking action. So here are the data. Research from Harvard University found that nearly 50% of Americans believe that our healthcare system and our providers are not compassionate. 2/3 of patients have had a meaningful healthcare experience with a lack of compassion. Rigorous research show that 70% of opportunities for compassion are missed by physicians, and compassion comprises less than 1% of all communications by physicians to patients. These data are compounded by an epidemic of burnout in healthcare providers. Burnout is characterized by depersonalization, which is an inability to make a personal connection. And in the era of electronic medical records, rigorous research shows that healthcare providers spend more time looking into computer screens than looking patients in the eyes. Based on all of these data, I conclude we have a compassion crisis indeed. But here's the big question. Does it matter? Does compassion really matter? Now, you may say, of course compassion matters. We have a moral imperative. It's part of the art of medicine. And of course, I agree. But is compassion just in the art of medicine? Or are there also evidence-based effects belonging in the science of medicine? And what is the evidence? In addition to being an intensivist, I'm also a physician scientist. In other words, I'm a research nerd. I like data, and my hypothesis was that compassion matters for patients, for patient care, and for those who care for patients. So I went to the biomedical literature, and I used a methodology called systematic review. So over 2 years through the National Library of Medicine, I reviewed more than 1,000 scientific abstracts, more than 200 research studies in total. And today I share with you what I found. The effects of compassion on patients, on patient care, and specifically the costs of care, and on those who care for patients, our healthcare providers. There are more than 20 distinct mechanisms of action by which compassion can have beneficial effects on patients. Let's go to the data. Let's start with the practical. If you have compassion for patients, You may be more likely to be meticulous about their care or have higher quality standards and lower likelihood of making a major medical error. But there are also physiological effects. Compassion can buffer stress-mediated disease. Compassion can also modulate a patient's experience of pain. There are neuroendocrine effects. So in patients with diabetes, research shows that high physician compassion is associated with an 80% higher odds of optimal blood sugar control and 40% lower odds of acute metabolic complications. There are also immune system effects. So in a University of Wisconsin study in patients with the common cold, high physician compassion, as rated by patients, was associated with enhanced immune response, shorter duration of symptoms, and lower severity of symptoms. And importantly, compassion can impact patient self-care. If you care deeply about patients, and they know that, they may be more likely to take their medicine. In a Johns Hopkins study of 1,700 patients with HIV, researchers asked patients, does your physician know you as a person? Knowing the patient as a person was associated with 33% higher odds of adherence to therapy and 20% higher odds of having no detectable virus in the blood. Compassion has also been associated with lower healthcare costs, which are a major factor in the health of our economy. In primary care, for example, research from the University of Rochester and UC Davis have shown that compassionate, patient-centered care is associated with lower discretionary resource utilization. So fewer diagnostic tests, fewer referrals to specialists, fewer unnecessary hospitalizations, and lower total healthcare charges. So here's the bottom line. If healthcare providers actually spend more time talking to patients, maybe we don't need so many tests and referrals. But what about time? We've all heard the expression, time is money, but time is also a vital factor in the efficiency and the economics of healthcare. So here's a staggering number, 56. Research from Harvard University shows that 56% of physicians believe they do not have time for compassion. This is in the context of a classic study from Princeton University on helping behaviors, which found that it wasn't the intrinsic belief of the importance of helping by the potential helper. It was whether or not the potential helper believed they had enough time to help. So how long does it actually take for a meaningful expression of compassion? To address this, researchers from Johns Hopkins University did a randomized controlled trial in patients with cancer who were having a consultation with the oncologist. And in this randomized trial, the primary outcome measure was anxiety. And if you have cancer, that's a pretty important outcome measure. So they found that patients randomized to a compassion intervention from the oncologist had less anxiety than usual care. So what was the compassion intervention? I could describe it for you, but instead I'm just going to read it to you. From the oncologist at the beginning of the consultation. I know this is a tough experience to go through, and I want you to know that I am here with you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We are here together, and we will go through this together. And at the end of the consultation, the oncologist said, I know this is a tough time for you, and I want to emphasize again that we are in this together. I will be with you each step along the way. So how long did that take? They timed it, 40 seconds. So this randomized trial shows that all you need is 40 seconds of compassion to make a meaningful difference. Importantly, 40 seconds of compassion can be a powerful therapy for the giver too. And this is important because these data are not just applicable to healthcare workers, but to everyone here today. Science shows that compassion for others can have a direct positive effect on your own well-being. Neuroscience studies show that compassion for others can trigger reward pathways in the brain and positive emotion that can buffer or even counteract the activation of stress pathways and negative emotion. So, in effect, compassion for others can make you forget your own worries, at least temporarily. So now this is where the science meets the personal. A couple of years ago, after nearly 20 years of working in the ICU and meeting people on the worst day of their life, I came to a stark realization. I had almost every symptom of burnout. And let me assure you, that's not a good place to be. It can be a dark place. Currently, the recommended prescription for burnout is what I call escapism. Get away, detach, pull back, go on some nature hikes or whatever. But I was not buying it because I believed that the antidote to burnout had to be at the point of care. In personal connection, human connection, not an escape. So what was I supposed to do? Well, I did the only thing I knew how to do. I took the research nerd approach. And armed with the data that 40 seconds of compassion can be a powerful therapy for the giver too, I decided to do an experiment on myself. I was the only research subject in this experiment. I was the N of one. So I tested the hypothesis that my 40 seconds of compassion would transform my experience. I connected more, not less. Cared more, not less. Leaned in rather than pulling back. And that was when the fog of burnout began to lift. My 40 seconds of compassion changed everything for me. Now, you might be thinking, I'm speaking on the power of compassion. I must be the most compassionate doctor. But the truth, if I'm being honest, is that I'm still a work in progress. I'm working hard at compassion every day, but I see it now. And thankfully, science shows that change can happen. I used to think that people were either wired for compassion or they were not. But the preponderance of evidence in the scientific literature, both in healthcare workers and in the general population, shows quite clearly that compassionate behaviors can, in fact, be learned. And that is good news indeed. So now it's time to answer the big question that I posed to you at the beginning. Does compassion matter? My systematic review of the literature now complete. 1,000 scientific abstracts, 200 research manuscripts, and one life-changing N of one experiment behind me. I now conclude with confidence. Compassion matters. For patients, for patient care, and for those who care for patients. Compassionate care belongs in the domain of evidence-based medicine. I no longer believe in this paradigm behind me, this historical paradigm. I now believe in this one. Because I found that there is science in the art of medicine. And the science is strong. I like to call this field compassionomics. It's the convergence of the science and the art of medicine. I will close just by acknowledging that you don't have to be a healthcare worker to feel burned out. And if you do, I suggest that you test the compassion hypothesis for yourself. Do your N of one experiment. Look and see those around you in need of compassion and give them your 40 seconds of compassion. See how it transforms your experience. But don't do it because I say so. Do it because science says so. 40 seconds of compassion can change everything for a patient. It changed everything for me. It can change everything for you too. And that is the power of 40 seconds. Thank you.
So, Dr. Wrong way. Tresiak? Not sure how to say his name. He is chair of internal medicine at Cooper Medical School, and as he said, an intensivist. He has actually written a book on compassionomics. I haven't read it yet, but I bought it, and I will read it. So I encourage you to consider that. If you Google this guy's name, you'll see another talk that he also did on compassion, which led to a little different take on the way he approached it. So you can learn to be more compassionate. So summary: recognize difficult patients are really just patients that have increased needs. Strive to understand those needs and help those that you can. First, do no harm. What you say and how you say it matters. Words are powerful, even more powerful when they come from a physician. And learn to be more compassionate for both your patients and yourself. Don't be stubborn. Okay, questions, comments? Yes.
So my question is, for me, I'm a very young faculty. I've been practicing for just a year, and some of the things I've encountered just in this few year that I've been practicing is patients that you do it, and I feel like a lot of So I feel like, at least in pediatrics, we do a lot of compassion, but we have come across some patients that are just, they outrightly come with some implicit biases. So I've had patients that as soon as my intern walks in, introduces herself, they just refuse to talk to them because they have an accent. How do you suggest we deal with those kind of patients? Because it's a learning experience for them, and I also don't feel like it's fair to give in to their demands to just change their physician. Because what if I, as a physician, refuse to see a patient based on the way they spoke or how they looked? I probably would be fired. So how do we deal with that when we have patients that do that to us?
So, everybody heard that. So what do you do in that situation? I don't have a quick answer, but I know the first part I would do is try to understand why you have that bias. And somebody else might have to ask them that question because they may be so strong that they don't want to listen to you. Maybe like the white supremacist, there's sometimes situations are such that there's no quick answer. But that's where I would start, try to understand why there's such a bias, and I think that's probably going to have to be somebody else's job. Other ideas on how you'd handle that?
And also actions speak louder than words. You don't know what you want, but if you're acting out in the direction that you want to be, that can help them understand you and realize that it's more than just your accent. Crazy bias. Your actions will speak louder than words. There's some people who just won't, regardless, but I think if they're judging you based on a characteristic about you, that'll go so far, but as you treat them and they see that they're being helped, I think that helps them understand you better beyond what they see.
So somehow you can have that patient believe you really care about their health and you really want to help, that may get past that. Now, giving them that message may not be easy, but that's the basic message you need to give to every patient. Other questions? I saw a couple other hands.
I can probably project.
Well, just in case.
Okay. Thank you, Dr. Harper. I think this is a really wonderful topic. I think that I'm one of the ICU fellows here. I think from the ICU side, we have these quote unquote difficult patients, but more and more we have difficult families, as we label them. And I think using the term difficult is it's almost inappropriate. Really, we really shouldn't be doing them. I think difficult, like how you were saying, we should really look at it. So you have high maintenance patients. The same way, I think we should get rid of the terms like non-compliant. I think when we say patients are non-compliant, we really don't know what it takes for them to be compliant. And they're outside of this hospital situation. But the term difficult as well. It's like I think when we freely use the term, oh man, this family's difficult or this patient's difficult. But what we're really doing is we're expressing that our frustration with the fact that they're not doing what we're telling them to do, right? And I think that we should, our job as physicians, I believe, is not to tell them what to do, it's to give them support through a healing process. Ultimately, we give them support and they must heal themselves. And in terms of calling them difficult, their family's difficult, we should really do what you're saying as far as change the way we look at it, and instead of being like, oh my God, it's a difficult family, got to walk into this room, look at it as a challenge, as an opportunity to help them and try to get them where they need to be. But I think it's a really, really important topic, and these moments of taking care of tough situations really define how great physicians we can be if we choose to accept that challenge. So.
We'll close. We're a few minutes early. Have a good day.